just to give a brief introduction of who I am a professor in public health and the director of the Prevention Science Research Center at Morgan State University. I have been at Morgan State since 2005, and I had the pleasure to work with Dr. Gharipour, even though his field is quite different from public health, seemingly different. I remember one day we were going like as colleagues and having lunch together, and he talked about this concept of the healing gardens and healthy designs and how an architectural design could contribute to health and how we could create interdisciplinary teamwork to make sure that that's happening. There is a whole science behind that. And that idea was so interesting, which resulted in a course, but also it's resulted in funded projects and algorithms. Like one of them is about identifying ideal places for clinics within Baltimore and that could be renovated among like the houses that are vacant and become an agent of change. So those kind of things are really interesting. And I'm glad that we are having this conversation. So my background before Morgan, I'm a trained physician, but then I moved on to public health for my postgraduate activities. I have been wearing hats as a clinician, administrator, academician, and now a research administrator at this moment. But then all of them came together under this umbrella of participatory research, which, that's what we are going to talk about. It's about like how we can do research together. So the community-based participatory research is a full mouth, but at the end, it's about like including different perspectives and creating partnership and coalitions of researchers that they're not look like one another. They're actually vastly different. Even their motives are different. The benefits they're seeking out of research is different, but their contributions are essential in order to make research relevant and make research result in some kind of impact. So without any further ado, I would like to delve into this presentation with you. And to frame the conversation, you know that right now we are facing multitudes of challenges: social justice, incarcerations, climate change, war, refugee problem, pandemic, urban issues such as homelessness, all these other environmental issues, and also leaky pipelines, the quality of the healthcare declining, through interdisciplinary frameworks, poverty, political turmoils. So these are all public health, and also these are all societal issues that are relevant to community-based participatory research. And the reason they are relevant is that if we want to solve this problem, we cannot do it alone. We need to adhere to the basic principles of life. You see, like how every form of life is so fragile, but then there is a strength, and there is also livelihood and beauty and tenderness and all those things, against the odds. You see, like the seeds grow and grow strong and big and come to fruitions. Even technologies such as like electricity that now we take it for granted. You see how many little pieces come together in order to make a lamp lit. So it's the same thing for research. We need to make research more equitable, inclusive, diverse, so that we can tackle issues around social justice, issues around, the problems that are multifaceted and needs solutions that are need to be coordinated. Now, with having said that, community-based participatory research, in short, we call it CBPR. It's a partnership approach to research with equal involvement of community partners in all aspects of the research process. Just to give you an example, we have two types of research, researching on human beings, human subjects, or researching with human subjects. So if you research on human subject, you basically treat them as like something similar to the lab animals or the and which we it's not like something that we could even think about. It's unthinkable. But that's how we treat, our human subjects if we don't incorporate their feedback, if we don't take into account what they bring, and we just are interested in our research questions. But there is another way of doing research, is doing research with human subjects, treat them as equal. Like when you're dealing with patient population, the patient experience, knowledge, input are a very important piece of the puzzle that need to be there. Also, patient advocates, all other sites that you're running the research, the community where the patients are coming from. Each of them hold important knowledge that together you can have a 360-degree iBird view of the problem. So, and in CBPR, you would like to involve all those who should be involved in the research process, and the mission is to improve health and increase knowledge. Now, the rationale so far, it's kind of obvious. We have complex health social problems ill-suited to outside expert research for the reasons that we just talked about. And then there is an increasing interest in health disparities. Disparities might be tolerated in a lot of areas based on merit, based on hard work, but in health, since World Health Organization treated as a right, not a privilege, so we want everyone to enjoy the optimal health. So any health disparities raise issues, ethical issues, and about social justice, about fairness of the community. And also because of that, there has been an increasing community and funders' demand for community-driven research and collaborations, because that has been considered the only way to address health disparities. And other ways of doing it has been so-called helicopter research. You go into the community, collecting research from human subjects. It's the same phenomena of the doing research on human subjects, and then leave that community and then publish the results, maybe in a journal, go to a conference, talk about that. But then that doesn't guarantee that the result is going to change the community. And because of that, there has been increasing interest in use of research, this line of research, to improve best practices, best processes, and to understand the importance of the local context and the contribution of that in order to make research more relevant, and also to create more community ownership of the findings. So the findings result in change. Now, just as a summary, CBPR is a promising, has been recognized now for about 20 years as a promising approach that's striking a balance between research and action. It fosters student learning opportunities, nurturing sustainable relationships, and also it paves the way for critical infrastructures, and also it would democratize all form of learning and knowledge. In a way, we need to balance the research and action so that we could achieve all of those things, and as a result, at the end, we will be in a society that every form of knowledge is respected and treated as important. Now, there are key principles to community-based participatory research. I would like to briefly just put it on the table, and then after that, I'm going to share two examples of CBPR in Baltimore that I have been involved with. So CBPR starts with community. I remember when I first started my career, I was contemplating a lot about what does community mean? Like if you're doing the research with community, who's the community? Like this person coming here is the community, the representative of the or that organization is the community, the one patient that I am talking to is the community, and each of those scenarios have their own problems because there are more than one organization, and in each organization there is more than one leader and staff, way more than one. And then each of those individuals have their own perspective, their own ideas. Sometimes even among two leaders of the same organization, there might be completely opposing views about the subject. So who's the community? If you're talking to me and I'm saying do it this way, is it what community wants or is it what this person wants? So, and that is now defined like that concept. Still, it's challenging, and that concept needs to be operationalized for every project you work with. But the way it's generally defined is that community is a unit of identity. Like if you are living in a neighborhood and your neighbors living in the same neighborhood, obviously, then you all have a collective identity as members of this neighborhood. If I am, let's say, from Iran and I have other fellow citizens that they're from Iran, we share that like identity among like us. If I am like belong to a certain interest group or someone who's campaigning for a certain cause, that identity could unite us. So it could be based on geography, it could be based on like interest, it would be based on genders or racial or ethnic identities or anything else. Now, you need to define that. When you have a community-based participatory research, the first task is to just clarify what do you mean by community. And then the second task is you need to think about what kind of representation you need from that community, because you cannot go to every organization, you cannot go to every demographics or anyone. But if you say, my community is patients and caregivers of like related to HIV, then based on that definition, you want representation from patients, you want representations from caregivers. Then you need to categorically think about different demographic of the patients. You need also think about different caregivers and different organizations. And also some of them are directly involved in providing medication. Some other things are wraparound services, helping them with overall support to the patients. Now, based on those things, you justify putting together a governing structure. And that governing structure would be like in form of a council or a community advisory board or steering committee that has representations from all these groups. And that doesn't mean that they are the community. They are the one that would be the voice for the community, and they are the one that bring in more community from their own interest. And that an ideal CBPR is when that governing group is going to set the strategies and is going to govern all of the task forces and all of the more specialized groups that need it under that umbrella. So as you can see, this is a hell of a task, you know. It's a huge, daunting mission, but the point is it's a rewarding journey because this is really how you can find fulfillment. And if doing right, you would see yourself that you are part of something that way, 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 way greater than you, but your role is so important in contributing to it, as anyone else's role is important. And everyone is doing a good job, and now it would be the best thing that could happen to anyone. So that's like in a nutshell, and we could have a full course about community and how to build boards and things like that. Now, the second principle is easier than this. It's based on like CBPR, it's based on focusing more on strengths and resources rather than the needs. If you look at the health system, it's structured based on the needs. And whenever there are needs, there has been offices set up, clinics, hospitals to address those needs with funding and budget. When it comes with the community, we want community to become more ready to address their own problems. So the first task is to see what kind of problem they can address without outside help. And that's why the first question is what kind of resources they have. And then once they clear about what they can do, then they could be clear about how the outside world can support them. And in that sense, there would be like lots of community engagement and readiness to change and efficiency into the system, because anything that is invested from the outside is wanted and desired by the community, and the community is ready to put it in good use. So now the second thing, the third principle is the collaborative and equity. Like it's a collaboration and equity aspect of the CBPR. CBPR should promote relationships that are equal relationships. People can have equal power. They're respected in their role, even though I have like some credentials behind my name and a community member may not have. I may partner with a person that is homeless because we have a CBPR project to address homelessness. And in that setting, that person who has lived experience of being a homeless or seeing homeless people and working with homeless groups is qualified as having a PhD in homelessness. So that's why when it comes to that partnership, that knowledge should be respected such as equal as any academic credential, and that has to be actively communicated and rewarded. That's how CBPR can work. Otherwise, if there is an imbalance in the partnership, if like I get most credits, you contribute vital information, and I just take the ownership of that, that's not going to work. So, and then the next one is to facilitate co-learning and capacity building. There is a lot of things that we don't know and we need to learn. So CBPR is about learning together. And as it was the sublime of the conversation, balancing research and action for mutual benefit of all partners is another point. Like we're not doing research now so that we wait for the result to become ready and then translate into action. Right now, the research and action are both together. Community partners may come and become interested in research because they really are interested in the job opportunities that research offers in their community. They may be interested in learning about some of the background information, which is in the literature review. It's not directly related to the research question, but they are that's what drives them, and that information could translate into improvement in some services, in some actions. So that's why we need to be clear that when we do this, we want to make sure that we have balance. It's not tilted by the academic desires to just get the data, and then, publish it in peer-reviewed journals. It's not also dominated by community that just serve and not collect the data. So there has to be a balance between like doing research, collecting good data, but at the same time serving. And then the last three principles are about like the focus on determinants of health from a local standpoint, disseminate findings to all partners and involve them in dissemination process, and promote long-term process and commitment. So CBPR, it's not a short-term thing. You are there forever. It's like a long-term friendship. Even if this project ends, the friendship is there. I have been involved with partners since 2005, 18 years ago, and they are still part of our group. And they have seen my son from when he was 4, and now he's 22. And I have seen their families growing up. So, and we have been together to so many places. So that's how it works. This become a new line of long-term relationship if you engage in CBPR. Now, let's, before going into the examples, make it clear that CBPR, it's an orientation to research. It's like doing research together. It's not per se a research like a method, even though there are methodological ways on how to do CBPR, but in general, it's the overall philosophy of doing research together as an orientation. And then it applies to just anything that has direct applications for the communities. Like you cannot think about CBPR for something for basic sciences or pure math or things that are so remote from application. But anything that you could see that the data could have direct impact on patients' outcome, on community outcomes, on solving societal problems, that's where you can apply this model. Now, let me just quickly go over some history based on like the two projects that I'm going to showcase. One of them is called CEASE, Communities Engaged in Advocating for Smoke-Free Environment. This is a community campus partnership to address tobacco use among underserved community that started, actually its roots go back to 2002, where, you know, the group of investigators from Hopkins and Morgan State University launched a survey. The survey resulted in some important data related to 2 neighborhoods in Baltimore, in Southwest Baltimore. And then they did a very good job sharing the data with the community organizations and community groups. So when I came to Morgan in 2005, they were at the dissemination phase. And then through interacting with those groups and in the data, I came across a small group of people that they were interested in tobacco, addressing tobacco. And we together wrote a grant to address tobacco among low-income populations. Like in that setting, just to give you an idea, about 60% of the adults were smoking, and most of the community members were saying that they want to do something about this, you know, and that was like 3 times higher than the average of the city. So that's why we partner up with 4 other people, one from like a local clinic, another from a church, someone from schools, and someone from health department. And then we wrote a grant that we're going to design an intervention and test that in a way that it's more relevant to the low-income communities. And then we make that as a model for the nation and even internationally. So that was how we justify the grant. And we said that we do our best to incorporate academic knowledge and other types of knowledge to come up with the first phase of the study. But then the second phase will be designed based on lessons learned from the first phase. We're not going to leave the community. We'd analyze the data that we acquire from the first phase, and then we implement the second phase. And now, through those approach, we said that we will actually, at the end, come up with the solution. So, and this is just the history in a snapshot. In 2007, we received the grant, which our first phase was in a clinic. We recruited 404 individuals, and we tested 2 different ways of quitting. And then it took us 4 years to finish this and analyze the data. And you will be surprised if I say that the result was so disappointing that we spent it like close to $2 million on this grant. And at the end, we had only 9% success rate. The both groups had equal results. We couldn't find any differences between the two arms of the study, and the retention was too low. So for any other projects, this would have been the end of it. Actually, there are tons of published paper that shows the same. We didn't do it worse than others. But then, since this was about designing the next version, it took us about a year and a half to just read through the lines and come up with a new model. So the new model was, so this failed because clinical setting is not a good place for tobacco cessation. Tobacco cessation based on this data and what we learned requires active support, education, and that could be provided by some trained peers and local players rather than the clinical staff. And then the new model was about training such peers and engaging them in designing the curriculum and finding venues such as their own church, their own organization, their own schools to hold classes. And then the peers get involved in enrolling the participants, as well as delivering the intervention, as well as just refining and optimizing that intervention through like the team works and the meetings that we had throughout the way. So, and this was very successful. Immediately, we had much better results that justified this to be funded. It has been funded continuously since 2007. Right now, we just finished a virtual version of the program and started a version of that it's in the schools. And as you can see in these pictures, we don't have much time, but there has been like, this is the clinic we started, and you see the classes, the outreach activity, all of the engagement activity, the programs. This is the health commissioner wearing our t-shirt and campaigning for us, and also, all these tabling and things that happen. So, the peer motivators contributed to developing this tool, which is now branded as CEASE, has been published extensively, and it's a resource that peer motivators around the world could use to educate and to prepare participants from low-income setting to quit and also to prevent relapse. And this is just the data in a snapshot. That clinical base, the quit smoking rate was about like 9.4%, retention was 13%. As when we moved to community-based setting, the quit smoking jumped from 9.4 to 21.1, retention to 51. And then when we made more enhancement, you see how it further improved to like quitting now 30%. And now we are at the point that if individuals come with our program for at least 6 sessions, half of them would quit. And this is like way less expensive because we train peers, and it's not like what we pay to peers. It's not comparable what we used to pay to doctors and nurses and the clinical fees and all those things. And a lot of the places that host these programs, they offer it like for free. This is their contribution to the partnership. And we have created so much job opportunities for site coordinators, for peer motivators, for other people to do this line of work. So, and we didn't stop there, because when the partnership grew, we were envisioning about, oh, this was such an important concept. We did this together, and see where we are, like back in 2007 and now in 2018, 10 years, it's like day and night. Imagine if we had other groups following the same path. This is not just about smoking. You could build partnership around anything. This is CBPR. But then they were saying, but those groups need to get support. They don't need to wait for 10 years. If we had the support that we needed, probably we would be in this place in 2 years instead of 10 years. So that's why we came about thinking about, oh, what if there was a center that dedicated to create infrastructure and capacity for community campus partnerships? And that's, we contemplated on that vision for 2, 3 years. And finally, in 2018, we found the right mechanism, wrote our dream as a proposal, and we got funded for like $24 million to establish a big center, which like a portion of that came into renovating a facility inside the community and creating a center for community engagement that you can see here. It's called Morgan Cares. Now, Morgan Cares is a hub for community and academic researchers to connect and form long-lasting partnership. The way it works, it's basically a network, like it's a flat organization. It's not like other organizations that there are presidents and vice presidents and chairs and things, and then things are hierarchical. Everyone who become a member, they have certain rights and they have certain votes over the whole network. And the job is like for let's say you come across this network, be matched and get connected to someone that it's across the line and have a mutual interest. And then little by little, that connection translate into partnerships, become turn into like ideas and innovative designs and concepts that partnership come up with. And those innovative ideas, like the ones that I just told you about, CEAS and these Morgan Cairns, be written into proposals and get funded and result in collaborative actions. And then those actions now produce fruits and results. And then you can finish one project, but then now you can go through the loop again. And you can work with more people, with new groups, around new projects, and then grow. And a lot of people, when you have this network established and working, come in at different phases. Like you may already have a project, like Dr. Gharipour already had the healthy design and a lot of it. So at that level, he was already at the collaborative action. And now, you know, the whole purpose of this model is we can match the need at every level with the services that we can provide. Now, and the network is about resource sharing, co-learning, networking, partnership development. It's also about organic mentoring. Like if you come to the center and then next week someone else come, you're 1 week more senior than one person, that person. And you can be that person's mentor by just showing them around, telling them about the facility, who's who, right? So, and that's how mentoring should be, because then you don't need to go to the top level to ask basic questions. There are always people helping each other, you know, at different levels. And then seed funding has been an important part of our project to our program to incentivize innovation and program development. So as I know my time is over, so I'm going to wrap up quickly. So far we have a steering committee that governs the whole structure. The CEAS project also has a research council, and they have been responsible for creating the bylaws and all of the governing policy documents, strategic planning, and initiatives such as the community award. Even they review the awards and recommend foundations. And then also for research, technical research aspects such as data compliance management and integration across other groups at Morgan State University in collaboration with other institutions. So the Community Award Initiative, as I said, is a way to incentivize innovation. Once a group of people met, like even 2% from academia and community meet, now we tell them that you can apply for an award. And then that encouraged them to think about what kind of ideas would be relevant. And so far, we have funded 29 of such ideas. And based on the model, we have provided services to build connections, like such as information sessions, linkage sessions, needs assessment, just for like the fostering innovations. People may meet and then they have some ideas, but then they're not sure if the idea flies. So we have services for them to share those ideas and get them reviewed and revised if needed. And then also the facility you saw is beautiful. I really invite all of you to come and check us out at some point. So we are open. People can make reservations of our spaces, bring in their groups, and also they can use the technology, any equipment that we have. Let's say we have um, tablets. You don't need to write it in your grant if you can just borrow it from us and bring it back, you know. So those are the kind of things that we do. And of course, as a dissemination hub. So for just tracking how well we are doing, we track the projects like those awards, the 29 projects that we have funded, which we just periodically check to see how much progress they have made, how community has been involved, or different partners have been involved, and what have been their outcome and impact. For the partnership, we also look at the perception of the partners about equity, whether there was a conflict, how they resolved the conflict. Were they able to do that? And then there are, based on the data and information that we get, we can have trainings and other type of support. And involvement of the different groups, commitment and benefits, how the benefits have been shared. And the whole thing is that these projects result in larger projects, and those larger projects bring in resources that community and academia need to solve their own problems. And in order to do that, we want to just do a good job making them ready. So think about like we see ourselves as coaches, that we are doing a very good job to just teach skills and make the players ready to just go outside the world and become the superheroes that they can, you know? So that's the purpose of the group. And so far, we have held so many conferences that it has been jointly planned for these kind of purposes. These are like lots of images you can see. And in a lots of them, you see kids have coming with innovative ideas, giving presentations, and then just, you know, it blow away. Everyone's like, this is the NIH, one of the NIH directors, that now they are in a direct exposure with community, not just through boring talks, through art and through other things. And these are the kind of the beauty of this line of work, that when you work with the community, when you work with the kids, then there are a lot of things that you learn. And they learn as well. So, and then we together can find, be ourselves in a better position to solve the problem. And this is like one of the things that youth did by just taking photographs of tobacco advertisement and tobacco problems in their own community, saying why they took that picture. And this became so successful that the whole city schools adopted the model. They put together an exhibition and they went through everywhere. They went to City Hall and put up there, and the kids like were talking about their pictures in terms of, okay, we don't want this in this community. So they would show the policymakers, the school official, and also as an educational tool. So these are the kind of things that are very fulfilling about CBPR. And sorry for being a little over the time, but thank you so much for this opportunity.